Top Med Talk.
Hello and welcome to Top Med Talk. We're coming to you live from Euro Anesthesia 2025, the annual meeting of the European Society of Anesthesiology and Intensive Care, here in beautiful Lisbon in Portugal. And this morning I'm very lucky to have Joerg with us to talk about the right heart and particularly right heart failure. Joerg, can you tell us a bit about yourself?
Yes, so I'm the head of Department of Anesthesiology and Intensive Care Medicine at the Heart Center in Leipzig, Germany, which is 200 kilometers south of Berlin. And one of our favorite research topics is right heart failure, because we started 2013 with the PacePort pulmonary artery catheter, which was originally designed for, as the name says, the PacePort or pacer pace wire in the right ventricle. During a congress in Las Vegas at the Bellagio, I heard the first time of that catheter and the way how you can measure right ventricular pressure with that catheter. That was by Dr. Jacobson from the group from Montreal, Canada. Since that time, we used that specifically in high-risk patients, and we connected a pressure transducer to that PacePort lumen. So we were able to monitor right ventricular pressure curves. So with that, you have a combination of pulmonary artery pressure, right ventricular pressure, and the right atrial pressure, the CVP. This combination of these three pressures allows you a lot of diagnosing right ventricular function. So unfortunately, till now, that measurements, especially of the end diastolic pressures, had to be made offline. So you have to use a software where you also can measure pulse pressure variations. And with that software, you were able to detect early and end diastolic right ventricular pressures. We know that in a healthy, happy right ventricle, this slope from early to late diastolic pressure is a horizontal slope with a maximum difference of equal or below 4 millimeter mercury. And we know that the right ventricle, in contrast to the left ventricle, is a ventricle who can cope a lot of volume because of that horizontal slope. Right ventricle cannot deal very good with acute pressure change. The best example is a pulmonary embolism, where the right heart fails immediately because it is not used to create high pressures. But over a wide range of volume, the right ventricle is able to keep the stroke volume. But at the end of that compliance loop, in a patient where you overload that right ventricle, this slope between pre and end diastolic will become steeper or oblique. And for us, this is a very early sign of beginning right ventricular dysfunction. I would not say failure, but dysfunction. If that becomes worse, then that slope gets a so-called square root sign. Immediately after early diastolic, and the diastolic pressure rises immediately. So then you get a steep curve. And that is just before the right ventricle fails. So that means if you use that right ventricular pressure waveforms, especially the diastolic waveforms, you can detect early RV dysfunction. So whenever that difference, which I told you between pre and post-op, will become more than 4, or let's say more than 6, then you should be very, very careful with volume. So if you need the right ventricle to produce more volume, more stroke volume, to feed the left ventricle, then you have to think about inotropes or milrinone or whatever, not volume. And that is for us a really early sign, as I mentioned.
So it's a great summary of the journey of your work from when you had that serendipitous lecture in attendance in Las Vegas to the point where you're developing new ways to measure right ventricular function. And I wondered if we could pick it apart a bit. And if you could go back and tell our listeners just a little bit about the normal right ventricle and how it differs from the left ventricle.
So the normal, as I said, works with low pressures. So the wall of the right ventricle is very thin. So let's say up to 4 millimeters. That means it doesn't have much contractility reserve. Left ventricle wall is between, let's say, 8 and 12 millimeters normally. So that implicates that the left ventricle deals with high pressures as it is needed, whereas right ventricle pressure is normally, the mean pressure is about 10. So that is one thing. So that is a low pressure ventricle. And because of that thin wall, of course, it can deal with a lot of volume. After load increase, so that means an increase in pulmonary artery pressure, acute increase, can the right ventricle not really tolerate. Slow increase, like in patients with pulmonary hypertension, the right ventricle will adapt. So it will become hypertrophic, and then it can deal with, in some patients, systemic pressures, like systolic pressures of 80 to 90.
And how common is unrecognized right heart failure in our patients, apart from in cardiac surgery?
I think in the last decade, there was a lot of research about the right ventricle. But before that, we were not aware that the right ventricle really plays an important role. So I think at least 20 to 30% of patients with right heart failure were not really recognized. And you can see that also in coming away from anesthesiology. If you look at the natural history of these patients with right ventricular failure, they come very, very late to the physicians. So they are really not well recognized. And the physicians wait a long time until the patients really get treated. So nowadays, with all that edge-to-edge repairs in the cardiologists, these patients get now treated, but it's a treatment of heart failure. It's not the tricuspid valve itself is diseased. It's because that right ventricular dilatation that causes that right heart failure.
So if you have an older patient, particularly one with cardiovascular or pulmonary disease, you need to have an index of suspicion about the presence of right heart strain or failure.
Yes. That's
And so what are the deficiencies of the current intraoperative monitoring when it comes to the right heart?
So most of the anesthesiologists will use echo, and me too. So we do, because I'm working in the heart center, and we do around 4,000 cardiac operations per year. So we use echo in every patient, of course. And I love that. And there are a lot of measurements you can do, like TAPSE or fractional area change. Or
Can you tell us about TAPSE?
TAPSE is the tricuspid venular plane systolic excursion. So that means that the right ventricle during contraction has a longitudinal contraction as well as transverse, but the longitudinal contraction that is measured with TAPSE. So you use an M mode, so-called M mode. You place it to the tricuspid annular plane, and then you measure the distance between end diastolic and end systolic, and that is the TAPSE. But TAPSE works quite well in patients with a untouched pericardium. But whenever, especially in cardiac operations, whenever the pericardium is opened, or when that patient had a cardiac operation, TAPSE is not longer valid to judge the function of the right ventricle. You can use fractional area change, where you measure the area of the right ventricle and diastolic and systolic, and then you have the percentage, which is a little bit comparable to ejection fraction of the left ventricle. The problem in that is that the right ventricle anatomy is completely different from the left ventricle. So in echo, the left ventricle is a chamber, and if you use two different planes, 90 degrees orthogonal to each other, Then you can measure that area, and then you will get a good estimation of ejection fraction. The right ventricle is semi-linear. That makes these fractional area change very difficult, or not as reliable as a fractional area change from the left.
Echocardiography is not continuous, is it? It's episodic.
Yes, that's it. What's also coming more and more into clinical practice is the right ventricular strain. And as you said, this is also an offline measurement. So that means you have to measure that, and it's good to have that as a baseline so that you really know, okay, this patient in that situation has either good function or not a good function. But continuous monitoring is not really feasible with this.
What are the deficiencies of the pulmonary artery catheter, if you're actually even using one in cardiac surgery anymore?
Yeah, we never stopped using that. As not for all patients, we never did that. I think that is not an indication for Swan-Ganz to use it in every cardiac patient, but in high-risk patients. High-risk patients means patients with pulmonary hypertension, patients where you have major cardiac operations which could harm the right ventricle, even if the right ventricle was good at the beginning of the operation, and in patients for tricuspid regurgitation, because tricuspid regurgitation, or in patients with severe tricuspid regurgitation, the RV function is based on echo parameters for a long period of time normal, because it ejects to the right atrium and to the pulmonary circulation. And after the repair or replacement of that valve, then the right ventricle has to do more work, because that regurgitation to the right atrium is no longer there if the operation was successful. So that means that the right ventricle has the risk to fail. So in these patients, we placed the Swan-Ganz, and now we use the new one, the new Swan-Ganz. As I told you at the beginning, these measurements between early and late diastolic waveforms were also offline analysis. So you have to use a special software, you can do that. It was, let's say, 10 seconds, 50 seconds, but it distracts you from the patient because you have to look at the monitor. Now with the new Swan-Ganz, the Swan IQ, for the first time, these values are displayed continuously on the monitor. And the next good thing in my eyes is that the stroke volume measurements, which is continuous in that Swan IQ, is no longer based on thermodilution, but on a beat-to-beat pulse contour analysis. That means you get changes in stroke volume very, very quick. So nearly online. So between 2 to 3 beats, you see if your therapy results in increase or decrease of your stroke volume.
And what's the algorithm or the mathematics behind those calculations in the Swan IQ?
So as I said, it's the pulse contour. So that is an algorithm where they measured a lot of patients, and then they had this algorithm where they measure these pulse contour in the right ventricle, and that area under that pulse contour reflects the stroke volume.
Right.
In contrast to the thermodilution, where you use either a cold bolus or you do it continuously by using the temperature gradient. And of course, this lasts a little bit longer. A little bit means 2 to 3 minutes, which is a lot in critical patients.
And what clinical research has been done with the Swan IQ?
Up to now, there are no studies because it's just launched in the market. So we were happy to be one of few centers in the world who had the opportunity to test that. And we did it in about 25 patients. And tomorrow we will test even more patients of that. So we were happy with that. So I can not tell you studies about that new IQ, but I can tell you our impression and our experience so far. Of course, it's limited, but it's there. And if I may start with that. So we used it in LVAD patients, so implantation of a ventricular assist device, left ventricle, because these patients are also very prone for right ventricular failure. When the left ventricle is really assisted through that mechanical assist device, then the right ventricle has to create that stroke volume for that assist device. And that is always a tricky situation. Up to now, there are no really very early signs for echo to predict if the right ventricle will be able to cope with that changed circulation. So in LVAD and in the tricuspid valve repair patients and in patients with pulmonary hypertension and bad right ventricular function. And we were quite surprised that it's really accurate. So we compared that early and end diastolic pressure measurements, as I told you before, also with offline measurements. So we did offline measurements like we were used to since 2013, and it was correct. The good thing is you don't have to do that anymore. You will see that numbers and you will see how that change immediately. Stroke volume, the same. You are able to do a thermal dilution bolus, and we did that just to see if the stroke volume or the cardiac index reflects the real situation. And so far, there was no difference. So it was in between that 10% difference. So for us, that Swan-IQ measures what he tends to measure. So that measures the stroke volume and the DPDT. DPDT means that is the pressure difference over time, which is an indicator for contractility. With that measurement, we have to do really more research because in that limited numbers of patients, there was a difference between the DPDT measurement in the Swan-IQ and the DPDT measurement on echo. So maybe it's due to the pressure transformation or whatever. So I'm not sure. But the end diastolic, the early diastolic pressures, the stroke volume, that is really accurate as far as we can say it in that limited patients.
And the product, which is from BD, does it look like a normal Swan-Ganz catheter? And what sort of extra kit is there that you need to use it clinically?
So it looks like, let's say, the normal paceport catheter because it has 4 lumen.
Right.
And you have to connect that. In addition to that, you have the continuous mixed venous saturation, which is another very important parameter. So you have to connect for pressure transfuses and all that. So it's a lot of things to connect, but the catheter itself looks pretty much like the old one.
And the mixed venous saturation measurement for our non-cardiac listeners, what information do you get from that augments the other information from the Swan-IQ?
So the mixed venous saturation was also available in the later versions of the Swan-Ganz from BD or Edwards at that time. And the mixed venous saturation tells you the oxygen delivery is enough to feed the cells with oxygen, because at the end, so the mixed venous saturation is measured in the pulmonary artery. So that means you have the venous blood from the lower body and the venous blood from the upper body, including the heart. And the heart consumes a lot of oxygen, as you know. So that means if you have that value, and if that value is above 65 to 70, then you know that your oxygen transport is okay. And that oxygen transport, of course, depends on your hematocrit mainly and on your stroke volume or your cardiac index. So if your mixed venous saturation drops, that is a sign that either you need a blood transfusion or that the patient is in a physiological state where he consumes a lot of oxygen, like in sepsis or whatever, or the cardiac output is too low. So this combined with the stroke volume and the pressures allows you a lot of informations which give you a good idea of RV function.
Well, it all sounds absolutely fascinating. So you're going back to Leipzig at the end of this meeting. What's next in your investigation of the right ventricle?
Yeah, we tried to set up a study where we really look at outcomes and how that in Swan IQ has an impact in the treatment, especially in early treatment of RV dysfunction, if that makes a difference. There are a lot of projects in my head, and we will see how it. But I'm really fascinating so far about that product because that is what I wished since I worked with that IQ and due to André from Montreal. He worked very close with Edwards in that time, so they were able now to create that Swan IQ.
Well, it's wonderful when your plans come to fruition, Joerg. Congratulations. And thank you so much for being on the podcast.
Thank you.
You can hear this podcast on our app and also on our website. We're on social media. We're on Facebook. We're on X. We're on Blue Sky. And we're also on YouTube. And if you look at our YouTube website, please give us a big thumbs up because every thumbs up helps. And we'd like to thank EACTA for their generous welcome to the meeting here in Lisbon, and also to BD and to GE, who are our major sponsors. And they let us bring TopMed Talk free and open access to the world. Cheers.
TopMed Talk.
Thanks for downloading TopMed Talk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook and X. Also, it's important to remember that TopMed Talk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.